So we're going to talk a little bit about some of the types of pathologies that we see and the types of conditions that you will no doubt read about on reports that are coming through to you, just so that we can sort of visualise it when we see it written in words. But we're all sort of familiar with most of the types of pathologies that we see on this slide here. So the system, an MRI in general, obviously, and it has been used historically and is still very, very good at detecting lesions in the soft tissues of the foot. So this is a deep digital flexor tendon injury on this lobe of the deep digital flexor tendon here. And this type of image, it's very, very useful information. There is virtually no other way of seeing that unless we do a CT scan under general anaesthetic. But you can't ultrasound that area, no matter what Denmark tells you. It's very difficult. So this is an excellent way of finding that type of lesion, and there are a whole raft of different morphologies of that particular injury, but as I'll show you later. But the system is excellent at finding those types of lesions, which are real. It really does change how you're going to manage that case once you know it's carrying a lesion like that. This stir image of the navicular bone here, you can see the navicular bone is very high signal, so it's bright. That appearance is again suggestive of, can be a number of pathologies, but suggestive that there is fluid accumulating in the bone. What's responsible for that fluid can be a number of things, but that type of image, unless there are structural changes in the bone that we could see on a CT or an X-ray, this is really the only way of seeing that in detail. We do know that that appearance, as I said, isn't necessarily the answer in itself. That can be indicative of other things going on in the navicular bone that we need to know about. But again, the system is excellent at finding abnormal areas of fluid or other substances in bone. I've mentioned the distal border, so the distal border of the navicular bone can be much more easily interpreted on using MRI, and the ligamentous attachments that are involved with the distal border, we'll talk about those a little bit later. And again, on the right hand side there, fluid accumulation or early degenerative damage of the flexor cortex. Again, there is no way that you're going to detect this on an X-ray at that stage, and it's probably too small a resolution for even to be detected on a bone scan, or to be sure that that's present on a bone scan. And these types of detailed images are extremely useful. The pedal bone, there are obviously a number of pathologies such as cyst-like lesions, which we can detect on X-ray, or we thought we could until we started MRIing them, MRIing horses and finding cysts where we didn't appreciate them radiographically. But it's really good also, even for conditions where you have a radiographic finding in the pedal bone. So this horse, both of these horses have fractured their pedal bone, which you'd see on an X-ray. You'd know what to do. You put a bar shoe on it, you put it in the box. You'd expect it to be getting on quite well in 8 weeks' time, and then if it wasn't, you'd put it away for a bit longer. Now, some of these horses don't come sound when you expect them to, and you think, well, why isn't this pedal bone healing despite potential radiographic healing? They're still niggling on lame, and that's where the MRI can really help you just get to the fine detail of that particular case. So here, this is an articular lesion, and we've got a little defect on the joint surface, which has started off some low-grade cartilage pathology and some osteoarthritis developing. And here you can see how close this wing fracture is to the caudal aspect of the collateral ligament here. So this is the collateral fossa of the pedal bone. This is the fracture running through here. And what we do when we get wing fractures, which should be very benign, is cause instability with all the ligamentous structures of that area of the foot, not just the collateral ligament. So when these horses sometimes don't come up sound, and perhaps in cases particularly where the fracture wasn't picked up very quickly, so they weren't box rested, and they've stressed the ligamentous structures on that side of the foot. So you're looking at desmitis or desmopathy as a cause of lameness in those structures rather necessarily than the pedal bone itself. So it can be very useful just to say, well, why is this case not coming quite as well as I thought it would?